don't think I'm bad, why would I think you think I'm bad? Okay? If I don't think I'm bad, why would I think you think I'm bad? I'm going to talk about self-stigma. It's not new, it's not even innovative, but it's personal to every single one of us here this evening and many of our friends across the UK and across the world, HIV positive or HIV negative. So I just wanted to start by asking you all, can you all close your eyes for a moment? I just want you to answer the following question. How many of you have ever had the thought, even once in your life, I'm not good enough? If you've had that thought, can you just raise your hands? Okay, so just keep your hands up and look around the room. Super. Good to know that we are on the same page and that we have a room full of self-stigma experts. So we can leave now. Just for a second, when you have that thought, I'm not good enough, and all of us have connected with that thought. We might have been on the way here and we had that thought. It might have been yesterday, it might have been last month. Can you get in touch with how it makes you feel? How heavy it feels when you're feeling I'm not good enough? How it limits you, how it separates you from other people, how you look at people around you and you think, God, I'm not as good as she is, or I'm not as good as he is. We really compare ourselves when you're believing that kind of a negative thought. And the difference in your life is absolutely incredible. With the thought, without the thought. Absolutely incredible. And that's the power of self-stigma. And it's an issue that, believe it or not, it's something that in the response to HIV we've kind of missed. We've really missed it until now. So I didn't want to assume, in terms of stigma is perceived and it can be very subtle. There's lots of different ways to look at stigma. We moved the slides around a little bit to try and make things faster, so I'm just going to see what's on these slides so I know it. Okay, good. So there's different types of stigma, okay? There's stigma, there is perceived stigma, when you think that somebody is stigmatizing you. When stigma is enacted, it becomes discrimination. When somebody actually commits an act, it becomes discrimination. And what you'll know is stigma and discrimination, no surprise to any of us here, they're widely documented. Because in many ways they're more easy to count, and in a way we can respond by laws that are going against discrimination. We can pass resolutions, we can adopt policies, so we're quite familiar with stigma, and there's still much more to be done to reduce stigma in the general population. But looking at self-stigma, in the words of Edwin Cameron, self-stigma, it's self-disabling inner feelings of contamination, shame, self-rejection and self-loathing experienced by people with HIV and those who fear they have HIV, even when there is no objective reason to fear rejection or discrimination, and even when there is good objective reason to believe they will receive external support, protection, treatment and acceptance. Now this is a definition by Justice Cameron, a High Court judge in South Africa, diagnosed himself with HIV probably about 15 years ago. And it's his way of actually describing self-stigma. It's much more difficult than social stigma and to address because it's less visible. Not only because it's less visible, but because its object, and therefore its victim, is actually the self. So you're really dealing with something very complex. And remarkably, as I said just now, and we were talking about it today, there's been very little to address self-stigma until now. Even though we have lots of interventions and programs that are working on stigma to reduce stigma, we've got very little programs that are actually working with people to support them to deal with self-stigma. So like many of you in this room, I've been engaged and working with HIV for over 20 years and been very passionate about stigma. Very passionate about all the campaigns that we were involved in that really did make change around the world. But all of this work is about changing them, what they think of us, what about us. And it's like turning it right around and really starting at home. So where is stigma greatest? It may or may not be a surprise to you to know that consistently people living with HIV stigmatize themselves more than HIV negative people do, up to 3 times as much. looking at the evidence, you can see that this is a study from South Africa, 2,300 people. And what you're looking at here is 10% of the general population in South Africa believed that people living with HIV are dirty, compared to 27% of people living with HIV who felt they were dirty. 13% of the general public believed that people living with HIV did something to deserve it, compared to 41% of people living with HIV who felt guilty about HIV. You can see the same pattern in terms of shame. So you're looking at the difference here between what I think of me and what I think you think of me. And there's a big difference. The stigma index, Alistair and Vivian are going to talk about this a little bit later on, but the stigma index is one of the biggest research tools we've had in the HIV community that's been rolled out over 50 countries, probably 55 or even 60 at this point. And it's collected data, it's done by HIV positive people, collecting data about stigma. And this is some of, I'm not going to talk about, Alistair and Vivian will talk about some of the data from the UK, but looking at how consistent it is across the world. The Asia Pacific Stigma Index study, over 4,000 people, ranging from 75% of people in Pakistan saying they were ashamed of their status to 54 people in Sri Lanka. Looking at the Zimbabwe Stigma Index study of over nearly 2,000 people, looking at 17% said they were ashamed and 21% feeling guilty. The South African Index study, you might have noticed, came out just last week. Over 10,000 people, and you're looking at, again, high levels where you're looking at nearly 30% of people feeling ashamed, 28% feelings of guilt. And then the UK study, I just looked yesterday to see for the 2009, and you have very high levels of self-stigma, 44% of people feeling ashamed, 43% of people feeling guilty, and new data coming soon. So, can you imagine all these stigma indexes, over 50 reports, and although the levels were so high in all of these reports, none of them had recommendations to do something about self-stigma. It was like we're blind. It's like there's been a blind spot. So, moving quickly, looking at self-stigma, I was really passionate and wanted to understand more about the beliefs related to self-stigma, and so carried out a study in Ireland in 2012 that looked at what is self-stigma and what are the beliefs of people living with HIV in relation to self-stigma. And the idea of the drive behind that was that because there was no programs, if we understood more about the beliefs, we could actually design a program that would actually support people to deal with self-stigma. And that program Deirdre and Steve are going to talk about in a little while. Just breaking it down, looking at the categories of core beliefs here, you can see that there are categories around disclosure, around sexuality, around self-perception, and around body, illness, and death. And within those categories, you've got all sorts of beliefs that are grouped around fears, fears of what I can or can't do, consequences of whether I disclose my status or not, and then many other beliefs. Sophie, you're going to use some of this, talk to some of this in a while, but this is the kind of these are the kind of things that we're thinking in our head. It's a punishment. I'm dumb. I'm dirty. I'm a disgusting person. I'm toxic. These are really powerful. Remember how you felt when you were thinking, I'm not good enough. So how can our services as doctors and our programs as NGOs be effective if we're not supporting people to deal with beliefs like this? And for years we've been involved in behavior change, but it's like scratching the surface, because if the beliefs are still there, how can behavior ever change? In the words, okay, so I'm going to leave that and send that to you later. What I love about this quote is, this is an amazing participant who just was able to articulate what it's like to feel so toxic inside and to feel less and less every day. Beliefs around not wanting limitations. They won't want anything to do with me. They don't care. They think it's dirty. Looking around restricted agency, all the things you can't do when you're believing that you're believing something about yourself. I can't have a child. I can't get a job. I can't travel where I want to do. All these limiting beliefs. So more of the same, it's not going to work. That's the bottom line. It's the beliefs that we are dealing with here. So what can we do? We can recognize self-stigma like we're doing here tonight. Recognizing self-stigma. We can be advocates ourselves, and we can take action. And we just added a new a new slide here, because we can take action if you'd like. If you're inspired by self-stigma as a result of tonight, you can simply sign this petition, which came out last week, a Dublin Declaration on Self-Stigma that says, yes, I think this is important and we need to do more. We can be honest and we can start with ourselves. This is about being willing to have the courage to start to look inside of yourself, and then from there move outwards. So that's something that all of us can do as a sector and as people. We can design and test and fund and scale up innovations such as the ones that we're going to hear about tonight. The program, the inquiry-based program, stress reduction program, the work of Byron Katie. That's one of them we're going to hear about. The other Sophie will present is around overcoming self-stigma through self-love and compassion. So that's what we can do. There is an intervention guide as a result of that research that's available for anybody who has a program that they think might work to support people deal with self-stigma, and the beliefs are all here. So if people have different methodologies that they would like to explore, this is available for people. We need to be part of the paradigm shift that actually is going to make change here. And today we were talking about this. Every bully needs a victim. And if one day the person simply stops thinking of themselves as a victim, then whatever prejudice or discrimination is happening ceases to have the power to degrade. So it's like turning stigma and discrimination totally around. And I learned this from Jo Manchester. I don't know if any of you here know Jo Manchester. She's in the UK, one of the founders of ICW, and she shared that with me a long time ago. So I just want you to remember that thought. If I don't think I'm bad, why would I think you think I'm bad? I wouldn't. And if I did, I would intimately understand that that was your problem and not mine, because I would be strong inside and have questioned my beliefs. So thank you. I'm not going to talk anymore because I really want to give time over to the program, particularly from Zimbabwe, and to Sophie. So thank you very much, and I want to thank Ben for bringing us all together this evening. Thanks.
Index, the People Living with HIV Stigma Index was developed in 2006. The process started probably about 18 months before, and the great and good came together in South Africa to try and develop an instrument that could capture people's lived experience of stigma and discrimination and measure it. Because it was acknowledged that stigma and discrimination are two of the greatest impediments to people's effective engagement and relationship to and with an HIV diagnosis. So it was an attempt to create an instrument which was global to capture people's experience. And the UK was one of the first countries in Europe to roll it out. So in 2009, 35 incredibly passionate, mad, colourful, passionate researchers came together to interview their peers, 167 across 45 community organisations up and down the country, so from Aberdeen to Jersey. I mean, and interestingly, probably this time round when we're doing the recce of organisations, about 20% plus of those organisations have gone. So it's quite an interesting landscape change. We generated quite a few reports. This was the kind of first bright and shiny low-hanging fruit that we launched at the House of Commons. It was launched by Annie Lennox before she became an HIV star. It was an incredible day, and we generated a Scottish report, one that was commissioned by EHPN looking at the migrants data, and one in 2010 where we kind of drilled into the numbers, looking at some qualitative stories. Not that that's me. It's okay. It's probably sings better than me. Basically to kind of drill into the stories, because percentages and numbers are great, but HIV lives in people, essentially not on balance sheets. And I think it's, having been involved in this for as long as I have, I think it's something that you can never see often enough. So that was the first rollout of it. This year, in 2015, we were funded to conduct a second rollout of it. And we felt that we wanted to kind of revise the instrument. So an advisory group came together made up of equally colourful, mental, talented people. Yusuf and Michelle were involved in that process to kind of revise the instrument to help support a UK context. We added an ethnicity framework. We looked at the sexual identity identifiers and put a really clear frame that was signed off by community against that, and developed a back end of it so the analysis could be conducted in a way that was useful. A resilience framework was added so that we could measure against resilience. So I'm at the stage whereby I know nothing, which is probably the most delicious place to be in any research project. We're finding things out at the moment, and there's some incredibly smart, brighter than I, number crunching at the moment. This is what the instrument looked at on the left. I'm not going to read it to you because I always find it tedious when people read slides. But on the left-hand side, these are the kind of thematic areas that we're looking to capture: experience of stigma in, types of stigma, and then what we can do with this instrument is ideally look at the layers of stigma and co-stigma against the headers underneath. So the idea of looking at somebody's stigma, is the stigma experienced as a trans person in relation to a health setting, in relation to your migrant status, or maybe your sexuality, or maybe even your age. Obviously it can be looked at in terms of areas and ethnicity too. Results. This is what we had in terms of responses. We worked in two arms. There was an NHS arm, and we worked in 41 NHS clinics, and we promoted the study through over 120 kind of cross-sector organisations. So some that were HIV support focused, some that looked after injecting drug users, some sex work organisations, some organisations that worked specifically with BEME communities or young people. So there was quite a broad range, and these are the numbers that we came up with. As you can see, probably a little bit more from the NHS and the community, but we'd like to have done better in terms of our female respondents, and BEME communities were another area that we're slightly weak on, but you know, there's enough numbers there for us to be crunching viciously over the next couple of months as we move towards reporting. In terms of age distribution, the national data, as you can see, is at the top right-hand side. In some ways, the shapes are pretty healthy there. Ethnicity, again, that's shrunk a bit, but we acknowledge that we're not as ideal as we'd like to be around women and girls and BEME communities. Regional spread, that's the PHE data, and on the left, what we have. Time since diagnosis.
So you've got a couple minutes.
Okay. And pretty self-explanatory, really. And this is just something that we come up with. In terms of what I think it's going to be interesting to see where stigma is actually living. I think there's going to be a few surprises. We don't know where they are yet, but according to what we have this time around, 91% of the 1,570 that we had disclosed to the GP practice, 57 to dentists, 57% felt in control of that disclosure, and 58% felt very well supported, which I think is quite remarkable. There's a lot of projections, you know, as a community that dentists are really traumatic and really troublesome. It might be interesting as we move forward to see where the story really lives, and having this number set, which we managed to secure medical ethics for, a process I wouldn't wish on a dog, means that we can write it up really effectively. How many of your staff are aware of your status? How many of the staff are aware of your status? At the moment, we're kind of number crunching on the healthcare analysis, so there will be a report specifically on healthcare. At the moment, the two areas that we're battering through are the trans and non-binary populations, because there's an exciting event coming up that we're going to be chucking data at in Singapore? Bangkok. So it's WHO. Healthcare analysis, we're kind of battering through that, looking at everything against resilience. Idea being, is resilience a precursor for stigma or vice versa? Seeing how that's going to behave. Moving towards the beast of a report, which is under discussion at the moment, and the idea is we're hoping to create a series of report cards, if you like, bite-sized units of action around regional focus areas, and then again, key populations. So BMSM, BEME, people who inject drugs, sex workers and trans persons, so that after consulting with those groups, We can look at what the policy and advocacy needs and agendas are and provide data that's fit for purpose and relevant, rather than just giving top-down, here you go, this is what you need. So there's a whole spec of work around that over the coming months. And that's, something's dropped off there. Okay. I guess asks what we're going to be doing over the coming months. There's going to be these consultations. I don't know whether ReShape might be the forum to be involved in driving some of the drilling into those areas that we're analysing. Maybe getting groups together through ReShape to look at how those conversations can move forward. We're going to be doing some of it out of London, but certainly the London hub of it might be an interesting thing that we could explore. I'd just like to thank ReShape for affording us a platform to have a conversation about some of the more challenging subjects in HIV at the moment. They've led on conversations about PrEP, and this internalised stigma is an exciting addition to that. So I'd like to acknowledge Ben and Sylvie, who is going to sing our PIAF medley for us later, and the various committees that are involved. We're living in really exciting times in HIV at the moment because there's two really cool studies. Stigma Index, which I'm a bit biased about, and an amazing academic called Megan Carl, who's based at PHE, led and drove a study called Positive Voices. So there's two bodies of evidence that are going to look at people's communities' lived experience of HIV and stigma. The Positive Voices is a little bit further down the road than us, but watch this space.
So I mean, today's very much around stigma as a discussion, and there were a few questions in this pilot. The pilot is not dissimilar to how we delivered the stigma survey in clinics. These were all individuals recruited through their clinics. Either they were asked through 30 of the HIV clinics to take part because they had attended in a given week, or they had been pre-selected from a record randomly. And we were trying to work out how representative we can get a sample of people living with HIV participating in a survey, online survey. We've got very good proof of concept, people will take part. The response rate was about 30% overall, which is not bad given people were just given a card and went away. There was no recall or yes, if you've been involved in research, that's probably quite high for doing very, very little. So there's obviously a lot of goodwill of people taking part. Again, difficulties in recruiting mostly women, and gay men completing the questionnaire online we know do much better than other groups. So we may, when we run it again, this time try and beef up, if you like, the arm recruiting younger people and women. And it was the same thing with the stigma index. And I think if we go forward in terms of issuing questionnaires through communities or through clinics, we have to make sure that we're actually getting full representation of individuals, because I think some techniques work better than others. And certainly for specific groups, numbers can get very small and people may not come up to clinics very often, or go through their usual, other community centres. So how we capture the understanding of those individuals is really important going forward. We're analysing the data from Positive Voices, and similar, it's all being done in Public Health England, mostly being done on a shoestring with scientists and registrars who are coming in to help us do that. But I think what's really exciting and important is that we want people living with HIV engaged with the analysis and with the data. So I think today's a bit of it's here. I know Alistair's actually, when we've had meetings, called out to people living with HIV through your steering group saying we're having a meeting looking at data, who wants to come? And people are not necessarily coming. It's a bit dry, but I think some of the discussions is how do we include people living with HIV, both from the sort of development of questions that are pertinent to their health or their perceived health and stigma in this case, through to how we analyse and how we present the data. It would be great to get a lot more engagement.
I think it's going to start getting interesting. It's going to start getting more interesting now, because the data set is what the data set is. But when you start joining the dots between people's lived experience and then directing, how would that relate to? And those are the things that community are brilliantly positioned to offer academia. You know, in some ways, I think, you know, I started working on this project when I was relatively newly diagnosed, and I was more useful then than I am now, because having somebody that asks the questions that we forget because we've moved on is always valuable. So there are no daft questions in these meetings, basically.
And we've also got some similar questions in positive voices than the stigma index to cross-reference, and so far they're very much the same, almost same proportions as you can see here of what people's feelings are about their HIV. The last bit that will be also very interesting, there were opportunities to add a lot of text, you know, free text for people to add, and there were lots and lots of comments from people, and that's another piece of work. So alongside sort of the data crunching, there will be also a lot of narrative to pull together, which is part really of the reports, and how to do that, and potentially additional qualitative work is really, really important, I think. So probably that's all I'm going to say unless there's questions.
I just want to acknowledge the amazing support that we've had from Public Health England, not just from Valerie's team, but there's been an amazing amount of in-kind support from community organisations and people that have come onto the advisory group that have just been phenomenal in keeping everything in check. It takes a lot of processes to operate a study like this on probably 50% of the budget we had 5 years ago. So you know, this time it's kind of much brighter and bigger, but only as a result of the in-kind support we've had. Thank you.
Thank you.
We had your interests at heart earlier on, so when we looked at the number of presenters and tallied up all of the slides, we realised that we weren't being very kind to you. So I dramatically cut back on what it is that I was going to present, because I think it's more important to keep it brief and to maybe share a video with you. But a couple of things just to set the scene maybe. I'm a development practitioner and I've worked in the sector for about 10 years, and back in 2012 I sat in a room not dissimilar from this one, and I heard a presentation from Nadine not dissimilar to the one that she shared this evening, and I had a bit of a revelation as I sat there. I was mortified, I suppose, by the fact that as a development practitioner I was managing a programme at the time in Zimbabwe for women and men living with HIV, and specifically around rights, and there was a strand of work within that on stigma reduction. So as Nadine spoke, it became clearer and clearer to me that there was a gaping hole in my programme intervention. So I didn't quite know at that moment what I was going to do about it, but I was pretty certain that I was going to have to try something. So what evolved out of that was a pilot programme, and rather than describe the nuts and the bolts of that, which of course I'm happy to share through other means, it's really important, I think, to hear the results which Steve will share with you. But more importantly, I suppose, to hear a little bit about the intervention directly from the programme participants. So I'll whiz through just a couple of brief slides and then I'll share a video with you that isn't very long either. There were a couple of different things that came together. I was working on a programme in Zimbabwe, heard the same kind of presentation from Nadine, and then we had connections with a research institution, a partner within Zimbabwe. So a few different things came together at that time that just made it possible to move ahead with an intervention. I mean, just to share with you the overall the vision that we had for it, which hasn't really changed, and the goal that we were working towards, and that is all fairly self-explanatory. In terms of the objectives, we started out with a number. I mean, at the very outset, obviously we wanted to reduce levels of self-stigma. We wanted to take the formative research that Nadine had done in Ireland and to see, can we take the intervention guide, can we devise and design a curriculum around that, deliver it in a context like Zimbabwe, and see whether or not this could work with support groups of men and women living with HIV in a different setting and in a different context to Dublin or the UK, maybe out of a clinical setting, and see how well would this work, what results could we achieve. And lastly, I suppose, what we were interested in doing is creating an evidence base within Zimbabwe so that we could leverage additional support, open a conversation, pursue a conversation, advocate for more attention to this neglected area. And we had the same agenda internationally. and this evening is part of that in a sense. So that is what we set out to do. We've been talking a lot about the methodology maybe. I think it's important, well actually I'll just share with you this and then we'll move on very quickly to the methodology. But it has taken kind of 3 phases. It didn't happen quickly, I suppose. It went as fast as it could. But just to outline the 3 phases. So heard the presentation in 2012. Very quickly moved to the idea that this had to be operations research. We needed to measure exactly what we were doing so that we could speak in an informed way and prove results. So we brought a research institution, the Royal College of Surgeons in Ireland, on board, and also a local research institution within Zimbabwe, Impact Research International. We designed a curriculum and we actually then delivered a 12-week program based on the themes and the beliefs that Nadine spoke about earlier, and that is what informs the curriculum. So we delivered that with local adaptation as it went, tweaks were made to it, and all the time trying to use opportunities to speak about it and to create a conversation and leverage support. The second phase last year, which is where we moved to try and localize resources for this work. So we have some certified facilitators of this methodology in the room with us this evening, and that's great. Nadine, Karen, who are based in Ireland and the UK, but we needed facilitators in Zimbabwe. This can only work if the facilitators are there and if Zimbabweans are equipped to move forward. So that was a part of what we did last year. And again, we continued with the advocacy, speaking about it wherever we could at conferences, submitting abstracts, creating spaces like this, or coming along to invited spaces and using every opportunity that we could. The third phase, which is where we find ourselves now, again, we're continuing with the research component. That hasn't changed. We're building on that all the time. Continuing to deliver the program, so we'll run another 12-week course this year, but it won't be external facilitators who'll do it this time. It's the trainee facilitators who are 10 amazing Zimbabwean men and women, and they'll do it with mentorship and support from external facilitators. And again, continuing to talk about it, trying to drum up support and resources for this work. So what is it? The methodology, really quickly, and you'll see more of this in the video. It's called Inquiry-Based Stress Reduction, the work of Byron Katie. And it's a really simple, on the face of it, assuming that you have a few fundamentals in place, like openness and honesty and the courage and some of those things that we've spoken about earlier on. But a belief, whether it is the one that we talked about earlier on, I'm not good enough. And then a process of inquiry, a step-by-step process that takes you through that belief and helps you just to inquire and to look at it in a little bit more detail and understand the impact that that belief has on your life and your efficacy, your agency, your autonomy, and so on, and then looking at alternatives to that belief. So you can just see the steps there, the 4 questions, and then how you turn that around, how you you'll see it in the video in greater detail, but it's that simple. These little cards are printed out on something the size of a playing card, and it's that simple in a sense, although it's obviously hard going, or but yeah, I'll show the video and you'll see what I mean.
My name is Cloud. I'm a Zimbabwean. I've been living with HIV since 2006. first I was a bit skeptical about the work because I thought maybe it was there to change the way I think, or maybe to teach me morals and ethics that I should adhere to. But as time went on, thanks to the capable, we were in the capable hands of capable facilitators. We were able to learn more about the work and know that the work is a tool which, if we are honest enough and are willing to ask the 4 questions and do the turnarounds, we'll be able to overcome the self-stigma in us. And not only that, as we apply the work in our lives, we'll also be able to remove all the stressful thoughts that we encounter each and every day. The work itself has helped me a lot in my life because I was someone who not only was stigmatized by other people, but I was someone who self-stigmatized himself. And as I did the work and I asked him the questions and then the turnarounds, I found that stigma going away, because the main thing that made that stigma go away was my realization that all the answers are with me and what I have is complete. I'm perfect as I am. I do not need someone to love me, someone to approve of me, or even someone to appreciate me, which is what I thought before. But now I know that in my life, what I have is okay. I have to accept reality. What is, is.
To live a better life like what I'm doing, I think it's better to follow the steps of the work. It works. Yes, it works. What gives you peace is what you say. If you say, I hate myself, and you feel peaceful, then it's fine. Then I hate Susan, or Susan hates me. What you talk of yourself, not of other people. I feel you will live a better life. Because I'm living it now. Yes, I'm living it.
I never imagined one day I'll be communicating with others. I used to be alone at home, doing my work alone, but I've realized that I should share with others, as well as my children and my relatives. Today I have peace. If I get angry or somebody says something bad to me, I have to ask myself, is it true? Then after doing that, I will do the inquiry, then I'll find the answer. Then I'll be happy after doing the inquiry.
The work, if you really do it, it works. If you follow the steps, it works. In my life, I feel it has changed. I don't have anything heavy within my chest like I used to do. I feel I'm light. I'm just living life. I'm just free.
through a very superficial level tour of the results. If anybody wants more depth from the results, then please ask us, and then we'll kind of like hook you up with the actual, some of the more hard data. Is this going to work? Yes, it is. So just, I mean, like data collection. We used the mixed methods methodology, not only taking things like pre-course baselines through things like interviews and focus group discussions, but then also the post-course follow-ups. So it's just the methodology by which we took all of the research data. We followed it in a fairly structured manner in as best a way we could with respect to conditions on the ground and ethics, etc., where we're done through the MRC of Zimbabwe. Maybe if I take the notes, it's a bit quicker. Sorry. Okay, so just to look at the sort of basic descriptive statistics of the participant group, it was quite small. We only had 23 participants, and it was a kind of like a fairly even split between the two groups. It was like an 11 and a 12, but you can see again the gender balance was a little bit kind of lopsided. You know, like a large proportion were aged under 41, so they were a reasonably young group as well. You know, most had completed at a certain level of education. You know, again, so it's a little bit kind of, the data's not exactly skewed, but it's just we looked at a certain population. You know, and then the number of, for example, people living with a stable partner, and some were currently having, for example, sexual relations, and some are not currently sexually involved, etc. Yeah. So looking at the outcome measures, we analysed the data along a number of different lines that were specifically geared towards the types of outcomes that we wanted to look at. For example, self-stigma being the top. But then, as we look further through the data, other kind of themes emerged. Now I'm going to talk about them in a minute. But things like fears of disclosure, even things like physical limitations. These a lot of them came out of the data. We used very much a semi-inductive kind of strategy. So we didn't just kind of like set our expectations beforehand. We added to our kind of like analysis pool as we went through the coding of the interviews, etc. So just to look initially at the quantitative part of the results. So looking at the self-completed questionnaires that the participants filled in based around different dimensions. For example, here there's things like around self-stigma and disclosure. So there's a number of measures in there, and Nadine, I don't know if anybody wants to see the full questionnaire, etc., that can be shared with you as well. And so just with regard to the weighting of the results, so that you can get an idea of what we're looking at when I show you some of the graphs. For example, those people that scored their results in the lowest category, they're recorded as none, okay, so no, for example, no stigma or no fears around disclosure. And then those that had an average score, that put them into the second bracket, we would say they had low fears of disclosure, low self-stigma. And then above, it's called significant here, but you could call it major or high or whatever you'd like to call it, okay. And we followed this for all of the self-completion scales. Yeah, and so just this first one is probably the most, I mean, all the data follows a similar trend anyway, but just to take you through it. So looking at the baseline levels of, oh crap, no, I didn't need to do that, I'm sorry. 2 seconds. Yeah, so self-stigma at the baseline, so immediately pre-course, pre-intervention. The level of people with, low levels of self-stigma was itself low, and there were intermediates, and then almost half of the participants had high levels of self-stigma. And then at 1 month follow-up, we observed a significant reduction in the high levels of self-stigma and a significant increase in the levels of low levels of self-stigma. This effect was also maintained at the 3-month follow-up as well. So we were able to see from the intervention itself, immediately following administration of the intervention, and also at an extended period thereafter, they had this significant reduction in levels of self-stigma. And also, sorry, this is kind of slow, fears around disclosure followed the same trend. Furthermore, depression. So this was analysed, for example, on the scale using items from the CESD scale for depression, so it's a validated scale. But again, the actual trend that we saw within the data was the same. This does work, yes. So the basic general take-home message, and we'll show you like later all of the full data from the analysis, but most of the measures improved significantly immediately at follow-up. And then more significantly, especially at the 3-month time point and the extended follow-up, they were also maintained, so this effect was still ongoing. And then in some cases, like continuation of doing the work and of performing the intervention, and repeated kind of practice of the intervention itself showed this in some of the measures, They may not have been significantly reduced at 1 month follow-up, but then when we got to the 3 month stage, it had kind of almost embedded itself within the mentality of the participants. And even better, no measure got worse, so we didn't do any harm, which I think is probably a very nice thing to note. But then obviously the study itself has limitations, not just in terms of the small sample size. Things like the desire to appear as a genuine case may have also skewed the way that people have reported their own levels of self-stigma, etc. Things like courtesy bias. So the intervention itself is a very intimate thing. There's a lot of one-on-one work with the facilitator, so there may have been a chance that courtesy bias could have crept in there. But certainly, in terms of the positive outcomes, so what else happened to these people's lives? And it's like Alistair said, HIV lives in people. It doesn't live in a balance sheet. And so to explore that a little bit more fully, we then undertook this qualitative analysis. So I'm just going to dive into that a little bit more deeply just now. Ben, how much time? Sorry. I've probably been rambling on a little bit too long. So just to go over our qualitative analysis strategy, our overall aim was basically to discover what were the participants' thoughts and perceptions of living with HIV, self-stigma, and the impact of the intervention itself on their lives. So we then rolled out this qualitative approach. So from, for example, the interviews and the focus groups, we coded the transcripts and then looked for the specific themes that were coming out from these. And then if you just look at the emerging themes from the pre-course focus group discussions, I'm sure a lot of the audience here will either have experienced some of these things firsthand as people living with HIV, or as clinicians or practitioners who are working with people living with HIV or supporting those people. Things like fear, embarrassment, hopelessness, anger, shock, all of these things, the negative emotions. But then when we started to analyze the data following the intervention, the emerging themes were almost like an opposite. I mean, it's not an exact opposite, but things like change, it was the biggest component, and it's not just people mentioning the work as being a change, but changes that happen throughout their lives. So we're not looking at an intervention that only targets one specific thing. It's not like a pill that you can take and it changes one actual measure. We're talking things that have worked across all levels and throughout these people's lives. So just to look at the coding strategies, so if you just bear in mind the middle column and the end column here, so these were the main categories that we looked at, and there's more in the analysis as well, but things like worthlessness, things like feeling worth less than others, or hopelessness, they can't go on living. Why should I bother taking my medication? I'm just going to die anyway. I'm not going to bother going and getting educated. I'm not going to enroll in university because I've got HIV. Nobody wants to take on a person with HIV. But what we realized as the analysis went on was the fact that, I don't know if much of the audience has heard of the RIF scales of well-being. These are specific scales used to measure well-being as a concept. So it's quite complex in itself only because well-being is not an easy thing to measure. I don't know if anybody saw the messaging that was coming out earlier this week. At any given time around the world, it's only around 20% of people are in good, perfect health, are not unwell in any way. So I guess that's that's a soundbite that you'll see in the media, and it's kind of it's a nice number to throw out there. But it kind of shows that well-being itself is a very multimodal thing. But anyway, Carol Riff's scales of well-being. I mean, we have things like self-acceptance, so how comfortable are you with yourself? Things like your purpose in life, your personal growth. These things all add together to promote well-being in the individual. And we found that actually, completely unsolicited, because this is applied retrospectively, a lot of the themes and the categories which came out of our analysis aligned pretty much perfectly with the RIF scales. But Nadine will probably tell you if we're having some discussions later about how we'd like to integrate the RIF scales into further analysis as we go through phases of the rollout of the intervention. So this is a completely unscientific, but it is it just looked nice as a graph. So just looking at the coding frequency of the themes that we had that came out during the analysis. So the numbers at the end after the dash just indicate the coverage. So for example, 6, this is out of all 6 participants who were interviewed after the intervention had these, for example. And the most frequent codes were education and knowledge, overcoming negative thoughts, and positive mentality. So again, this talks to the phenomenon of the intervention not just being a single time point intervention, but something that changes people's lives from within in an ongoing basis. So for example, education and knowledge, people would say things like, now I know more about this course, I can actually deliver this training to other people to help them with their lives. So the participants already, without prompting, were thinking not just of being cured or being better, but also to use that knowledge and to further their lives going forth. So it seemed to have that kind of the rolling kind of effect. And so when we just drill down a little bit deeper into the RIF dimensions and the way that we measured or the way that we analysed the interview data, if you look at the theme of change, it's a very general thing. But for example, people's lives have been negatively affected by their HIV status, obviously in this context. But being able to come to terms with this had really helped to increase their sense of self-value. You know, through doing the work, I feel I'm able to mix and mingle with anyone. So social withdrawal and these types of the things that we would take for granted to be able to do, but that are not necessarily given among people living with HIV in this context, we found that they had changed, or the intention to change was there. Then things like self-acceptance, so you know, maintaining a positive mentality rather than succumbing to the negativity. So I'm now ready to face any challenge that comes along my way. The thought of having limitations because of being HIV positive has since vanished. So in the absence of support which people had before doing the intervention, but being able to support themselves and to support others through the intervention has helped them change along these dimensions. Things like environmental mastery. So what I said earlier about being worried about that, you know, why should I bother doing any of these things? I'm not in control. I've got HIV, I'm going to die. These were turned around following the intervention. Things like purpose in life. So a lot of, again, just speaking to the theme of ongoing change and ongoing promotion of well-being and building their lives going forth following the intervention. For example, you know, as an individual, I would like to go out and meet people starting from my own support group. I will reach out to the people in my support group and do the work with them. So not only an intervention is also a tool that empowers the people to be able to help others. So basically, I mean, the overall message is all about positive change, you know. We have a lot of kind of very specific details of what changes have occurred into people's lives and the way that they've occurred and the dimensions that weren't really captured that accurately by the quantitative data. And obviously this is always going to be a problem when you're researching this way, so that's why I thought the mixed methods approach is a very nice one to take in. But anyway, the phase 3 tools now will incorporate the RIF scales to bring a little bit more structured dimension to the way we analyse and to the way that the people see themselves moving forward. And that's the end of that.
A couple of years ago, I was leading on a project, Positive for UK, Children and Family project, and there was a very specific focus, and it was about naming HIV within the family. And one strand of that was equipping parents to talk to their children about the child's diagnosis, or you know, the fact that they were born with HIV. So that disclosure of the child's status. And then the flip side would be about the parent talking to their children about the parent's status. So that's how this started. And in our work collectively at Positive UK, we see the barriers to talking about HIV. And I specifically didn't use the word disclosure because of how loaded that is. And it automatically creates fear in that person. So tentatively I used the word normalising it, but it was just let's name HIV, let's bring HIV into the conversation, because it's the elephant in the room. Now, the other part of this project was that it was also about including people who were affected by HIV. So we were engaging with children of mothers who were living with HIV. So we got both voices. And you know, we frequently hear about the elephant in the room from the person who's living with HIV. Well, then we started hearing about the elephant in the head of the person who's affected by HIV. So Ben introduced me via email to Nadine's work and passed me on all that she's shown tonight in terms of her thesis and the toolkit. And I've used that in the development of the workshop, so you are going to see that. And so part of this workshop was part of the programme helping people talk about HIV. So some of these are just going to be like real read ones. I'm not going to go through them and put you through that pain, but these are just definitions of stigma. And again, these are just the slides that I use in the workshop to help people distinguish between stigma and discrimination. Some know this, some don't. So can I click on? Okay. So, and then what is discrimination? And I think some of the, well not I think, but some of what has come through is people learning about that perceived stigma. They're clear on when they've experienced the direct stigma, but just that word perceived is not something that they could identify with in using that word. So once that came into the conversation, it then started to sink in of you know, actually this is all about fear, which put things into context for, you know, a number of people. So why are we concerned with stigma? Poorer social support, poorer mental health, low adherence, barrier to accessing healthcare, and barrier to disclosure of the HIV status. When I speak about the lower adherence to ART, I'm based in a couple of London clinics. Positively UK is an organisation we currently place in about 13 London clinics, providing peer support. I happen to work in two that have clinics called Lost to Follow Up and a Reach clinic. So it's those that are hard to reach, they've disengaged, it's about trying to re-engage. But then there is a patient cohort where that I do come across that are engaging. But when I have conversations with the patients, in amongst the conversation, when there is the issue of poor adherence, or even in some cases treatment failure, in a method, and I can't actually articulate it properly now, but I start to strip back like the reasons in terms of themselves as a person, as why they, in terms of where they are with their HIV diagnosis and status, and helping them to get some understanding that if you strip it right back, fundamentally, there's an element where it's about self-worth. I'm looking at a couple of faces in their blank, but it's, you know, am I worth this life-saving treatment on some level? Or am I going to continue with some form of self-sabotage by not taking that medication? So that's another conversation that has taken place. So here we talk about the perceived stigma, avoidance, social rejection, and shame dimension. And I appreciate some of this is mirroring what has already been shown, so I don't want to hang around on it too much. And this is a list that I put together, which again, Nadine showed a list, but I've taken this from people's lived experiences, from conversations that I've had with people throughout, you know, through the clinics or whichever. You know, I can't accept this. I mean, how, you know, limiting is that? I just can't accept it. There's no window of any other, you know, kind of thought. You know, I can't trust anybody. What I continue to find really fascinating, actually, is we see a relationship with a clinician, and then we see a relationship with somebody like myself, who's a woman living with HIV, and you know that they're different relationships, so you know that on some level the conversations are going to be different. But I had an example recently where I knew from talking to the clinician that there was a concern about a lady's adherence. I've sat in the room with this particular lady, and we're talking about the social issues that are going on for her. She's pregnant, she's not really adhering very well, and so she's being monitored. And I said, how you know, I understand that there has been concerns around your adherence. You understand the importance of that. How are you managing? Yeah, it's fine. Okay. Just so happens that her clinician walks in the room. Hi, you know, how are you doing? I've got your results, and clearly there's still an issue around your adherence. Yeah, I've not been taking it. So I've just gone, huh? But that's a reality of, and you know, she has a long-standing relationship with the clinician, and I'm relatively new, so I think there is a trust element there, but also that's what can happen, and I think that's why it's so key that when clinics and organisations can work together, because we're just, you know, for a number of reasons, but just from that one session, our relationship changed, and she was then able to, you know, I did challenge her, and I said, you know, look, we are trying to help you, and I, you know, if you are struggling, that's fine, and we understand that, and we accept that, but in terms of with your pregnancy, you really need to be undetectable here. You know, I sort of gone off course a bit, but just the whole conversation that can take place around treatment, it has come up quite a lot in the workshops. So what I'm now going to present is the toolkit, which this is the toolkit that I've provided in the workshop. Simple stuff that they can take away and use on a daily basis if they want to, and you know, and not if they don't want to. So the NLP exercise was again working with the belief change. Think about a self-limiting belief, and these were some of the examples that I gave, but I said I've placed these specifically around HIV, but if there is other stuff that you feel is more important to you at the moment, then, you know, please use that. Nadine said at the beginning, you know, hands up who's ever felt I'm not good enough. So, you know, I would give them the example, and then it's turning that around, and then I think this is the really powerful bit when it starts talking about, is it worth the cost to you? Is it worth the time it's going to take? And is the outcome in keeping with self? I think, but I also know that I read this in Nadine's work. Some of us walk around, some of us, i.e. in the general population, walk around quite comfortable, or not necessarily aware, and walking around of the belief that I'm a victim. And so when I've explained or shared in the workshop about a particular belief that I may walk around with, I'm like 12 years in recovery, and I have done quite a lot of sort of work on myself, and a big part of that has been about my belief system. And I identified with being quite comfortable in being a victim. You know, part of changing that belief is I had to decide, am I willing to let go of playing the role of being a victim? And that isn't necessarily going to happen overnight, because that's been quite a comfortable role for a period of my life. And is that going to keep me feeling in an authentic place? Is it keeping within my, you know, in my integrity? And then, so to flip around that I am a victim, what's a more empowering belief? And then it's giving, what does that look like? What does that feel like? What does that sound like? And we do this exercise in the workshop. And it's not a particularly quick one, but it's a very powerful one. And some of the stuff that was coming up in the conversation before I started around physical health, the comorbidities, the diabetes. What has come through in some of the workshop evaluations is where people have applied it around their sexual orientation, their ethnicity, whether they're a migrant, drug user, you know, like the stuff that you were showing, Alistair, on the stigma index, because that might be more prevalent than something around their HIV. So again, it's another tool that you can take way beyond the subject of HIV as is yours. How we doing? So these are, again, this is the material that I got from Nadine's toolkit. This was another tool within the workshop. One's around disclosure, perception of thoughts of others, the impact of stigma, the secrecy, the burden that we carry, is very powerful for quite a few people. Sexuality, sexual pleasure and intimate relationships. Now, another tool and another thing that we did in the workshop was mindfulness practice. So we did a 10-minute meditation halfway through. And for some, it was the first time they'd ever done that. For others, they were familiar with it. But it was recognising, for some, actually how powerful it was when they brought themselves right back into the here and now, and their head was just not in, you know, across the road over there somewhere in the future. But fundamentally, one thing that, you know, needed to be applied in this ongoing process is the willingness to try and change that belief system. So I sort of just put this in here to show that part. And then, because people can have very distorted beliefs about what love is, I just put this in. To give them something to work to if that was challenging what their belief or experience of love may have been. And so, before I flick onto that one, I want to read out a testimony that came through. So this is what the section I'm going to now. So this is from somebody who attended the first one over a year ago. The Overcoming Stigma workshop was a watershed moment for me when I realised shyly how far I had been stigmatising myself. I realised in the workshop, and particularly through an NLP exercise, how this self-stigma had led me to hold some negative beliefs about myself, not only in terms of my body and personal relationships, but also around how I am in the wider world. A year after the workshop, I am still working with the NLP exercise towards holding empowered and positive beliefs in all areas of my life. And others were so powerful and necessary, best workshop of its kind I've been to date. I won't read them all out, you can just read them. But this is, I don't have like figures, I couldn't collect it in time to be honest, but thanks to Christian for providing some of this. But as the bottom one, around the secrecy, really helped me understand the depth of my fears around what other people will think about me if I disclose. And all of them, I have to say, all the participants have just said, this speaks to me on so many different levels, and I personally absolutely love delivering it because it does. It's spoken to me and it can still speak to me, but it just speaks to everybody in the room when I'm you know, delivering it to people who are living with HIV. So I just put that in as well. Okay, so does anyone have any questions?
There's a lot of information that's been shared, both in work that's happened in Ireland, work in the UK, and also in Zimbabwe. Are there questions that people just want to start to get clarification about what they've experienced, what they've heard, how it feels to them from what they've seen? Well, please.
I just wondered, with the kind of the tools of the process and the way you all talk about different things, do you generally apply it in a kind of one-to-one basis, almost like a one-to-one therapy? I don't know what words to use. Or because obviously you were talking about workshops, is that kind of group? Does it work in a group situation basically? Which I think is the answer is yes. But do you use it in one-to-one situation as well? And is there a preferable kind of way, or just is there anything to compare or contrast? I'm just interested in whether you get better results one way or another.
Well, the measurements that Steve presented weren't necessarily, they were the result of a combined intervention which featured both group settings. So there were 2 groups in Zimbabwe, and they both had similar numbers, about 12 people. And what that curriculum and that 12-week course looked like for those 2 groups were weekly workshops of between 3 and 4 hours, and then one-on-one sessions that each person had an hour a week, one-on-one, and it was a combined, it was the combination plus homework. People did their own work and, did their own practice, if you like, on top of that. And so the results don't delineate or don't differentiate between a one-on-one intervention as distinct from a group one. It was the cumulative effect of all of that.
Which is what you're saying anyway, I suppose the whole thing only works if you can do it yourself with others.
Maybe just to also add in other areas, it's also very powerful. One-on-one is a very powerful way to experience it as well. And it's as effective. We just haven't, that wasn't this program.
Yeah.
But yes.
You talked about it using in your family.
And maybe just to add that a feature or a component part of how some of those 2 initial groups, the 10 people who are going on to become certified themselves as facilitators, a part of the process to reach that point are one-on-one sessions amongst mentors or peers, and where they co-facilitate one another, and I suppose experience that as a session, but also give constructive feedback at the end of it. What worked for you, what didn't work for you. So that's a component part of it as well, the one-on-one.
Sorry, go ahead. No, it's just an add-on question to that. Can I please just ask the group, as facilitators and as people working with people living with HIV and as clinicians, if you were to take on an intervention like this and you were to roll it out amongst your own work, I mean, what would you prefer it to be? Would it be a one-on-one thing, or what shape should it take?
I think a combination, like you said. I think just from experience, depending on what order you would kind of put it in, a group one can be slightly overwhelming, and obviously it depends on so many variables. I think whether people have been newly diagnosed or not, or whether they've been new to the group, or I mean, so many things that I know everyone takes into account. But I would suggest a combination as part of the program, whether that's a one-to-one to kind of bookend it. I don't know, but I think I wouldn't do one on its own.
Can I just say that, I mean, we do it in both. There has been the designated workshops, but I certainly, I mean, I've continued to work with one lady over the course of 1 year since she attended the workshop, and in that time she's left her partner, who she was, convinced that she was going to marry. But a key part was that it was so obvious that he couldn't accept her status. She couldn't disclose, and so she did a load of work on herself and the self-esteem and the self-acceptance really, and disengaged from the relationship and is a lot happier. And literally did the affirmations every day, just really took it on board. But I think, as you probably know, it's like some people like a group environment, some people prefer one-to-one. And actually sitting in a group, and this was some of the feedback, sitting in the group, there were some people who were very quiet and they didn't want to, and rightly so, within their right, they didn't want to share what that self-limiting belief may be, just as an example of that exercise. They didn't want to expose themselves that much, but then, so groups for some and one-to-one for others.
Christian, and then Catherine.
Oh. It'd be interesting to know about, to learn more about accessibility, and specifically around sort of tailoring this program to reach sort of other audiences than the obvious demographics that that kind of engages with programs like this, sort of self-management, sort of stuff like that. And especially if you have any feedback from your work in Zimbabwe, from your local facilitators, where the kind of what worked for them in delivering those programs with sort of Zimbabwean audiences, or for instance, sorry, I forgot your name. You said you use it in your home. Kind of how you manage translating this language, because it's quite work. It's quite a you need a certain level of understanding of English language first of all, or a certain level of education to even understand some of these words. So I wonder how you manage translating this language, into a language that your children could easily grasp.
So just on that, there's actually a book called Is It True? And it's a kid's book. And I just sit down with them, and honestly, I don't have to do very much. All we do is read the story, and they go, "Oh, I told you that this happened to me, and this is what happened, and what, these kids are so brilliant, right? They just gush, so it's brilliant. It's easy to do that. The hard part is us, because we've built the onion, right? We've got the sheds and the layers and the layers. But actually, the funny thing is, I am so not the expert in the room on this stuff.
But you're just as much.
Yeah, so for me, I think it's just about, I think this is hilarious, I'm having this conversation, because I'm just debating about going to school for the work, which is all happening. So, for me, it's about just, I see it all the time. It's this, who would we be without our story? We all have a story that we've built up over years. I have a sick mother, we all have this big thing, and we just get back to it, and we just scrape away the years that we built up, and it's finding a way to the truth, really, and just finding the reality. And once, I think my kids are a great tonic, because actually they just show you how quickly they get back to the reality of what it is, and they go, okay, I'll just take that and walk away with it. Whereas we're just so much more difficult to reach, because we've got so many more stories.
Yeah, our onions are much
bigger. Yeah. But actually, when you start to do it, and we were just having this conversation before, but you actually don't want to let go of your story, because you get lonely, and your story's been keeping you company for years. It's like, look, you can come with me, I can just go on my own. And it's actually scary, right? That's the scary part. That's why I don't want to go to the school, because they're going to make me really look at myself. But the reality is that's the truth, and you can go from a better place, you can move on and find a better reality. I really can't believe I'm having this discussion.
It's wonderful to hear Susanna speak like this, and I want to just point out one thing here. She started off by saying, I'm not the expert in this. And you started off by saying, it's very, you'd have to get the language, and it's a bit complicated. The only thing you need to be able to do is have an open mind to answer the questions, and then you're an expert, because it's an expert in yourself. That is how this methodology, that's why this program is so successful. And obviously we're here presenting the results in a way that as a society we can absorb whether it works or it doesn't work. All you have to do for yourself to feel the power of this is to actually question something that causes you some stress. And the expertise comes actually from within you. And so listening to Susanna describe it, it's just perfect. Absolutely perfect. And you're asking about the guys in Zimbabwe. They are phenomenal in terms of their ideas for where this is going. We had no idea when we started on this journey where the hell this thing was going. None. And they are just bringing it into their own lives, into their own realities. At the moment, the program has taken a turn where we were kind of emulating an international certified program and trying to create that in the context of Zimbabwe, and so trying to support them to become trained. And it's taken off now. It's going to go into prisons in Zimbabwe. So because they're working with prisoners in their work, they're taking it into prisons to offer drop-in clinics to prisoners living with HIV. They're taking it into the community now. We don't know yet how they're going to experience taking it into the communities, because that's now the phase that they're at. But their ideas for taking it into the community are phenomenal. They're going to sit by a community wall in a district in Harare, and they're going to go into a local support group and say, I'm going to be available there from 3 to 5, and you know, come along and here's that yellow card that that Deirdre showed. So we're going to learn how creative they can be, but it's like all of us, you are creative in your own. It taps into whatever is inside of you. So it, you know, George, it will tap into diabetes for you, and you might think, God, yeah, I really, this could really support me, or it would, you know, the comorbidity that you were mentioning there, that's where you might bring it.
I'd like to say something about that, because I've been dealing with chronic pain for 59 years, and I find it really not acceptable that you just tell me I'm hanging on to a story.
Oh no, I'm not saying your story, I'm talking about me.
You deal with your own onion, and I think that George has an onion that is different.
Yeah,
Like
absolutely.
mine. But we put a huge amount of effort into pain control, dealing with different medications, all sorts of things. And that is quite a difficult thing. And it shouldn't, and also children, you know. A mother who was HIV positive said to me that her children were being bullied at school because they found out that she was living with HIV. And that's reality.
Yeah.
So, you know, they're not self-stigmatizing, they're being bullied, in my opinion. So I think that has to be taken into consideration too.
I think self-stigma for me is fascinating because the emphasis is very much on the self. I mean, you know, somebody actively being bullied, I mean, that's something that's actually happened. But your belief, your internalized belief systems, which is something that this intervention is looking to support. I mean, for me, my relationship to my HIV is a business function. If I don't execute well, quite frankly, I'll die. So for me, the more real I can get with regards to my relationship, not anybody else's. He said that she thinks that's bullshit to me. For me, my internal relationship to and with what HIV means for me, and there's various bits to that, how it functions, how I engage with a medical model, how I adhere, all that stuff. The more I can be real with that in terms of accountability, the more effective that relationship will be and the easier it will flow. I think if you're operating that aspect of your life from a currency of denial or delusion, that costs, and the interest rates are never favourable. So this is not a tool for everybody, and maybe not for anybody at this time, but it's just a tool that might be useful for people to get real with regards to the relationship to HIV and with HIV. It's not a solution for everybody, it's just a tool.
Sorry, 1 second, I'll give you next. Deirdre was first, pardon me, Catherine was first.
I have a question, and I don't want to come across as cynical in any way, because it's not, I'm not attempting to be cynical by asking. But because of the role of ReShape in terms of looking to act in terms of making change and potentially influencing policy, I'm kind of curious, and Sophie, I wanted to ask you in particular in terms of the intervention that you guys have run across to the UK and sort of how you've managed to make it happen, and particularly sort of even how you managed to get it funded. And this might be a discussion for all of us, because there's a lot of evidence for decades around the impact of psychological interventions, one-to-one and small group interventions, that have all been defunded, quite frankly. You know, psychologists have been pulled out of HIV clinics. My understanding is that as a mechanism for managing what's happened as a result of that, and I think it's a brilliant thing, HIV organisations are moving into HIV clinics and picking up on the peer support, which actually, frankly, might be a whole lot more appropriate than having a psychologist. You know, it depends. But in terms of a costly, time-consuming, you know, expertly led intervention, how do we make the space for more of that to happen when we're struggling so hard in an environment that is dominated by, you know, cost outcome models? And I get the point that this is really incredibly hard to describe, and I don't even think we should try to describe in terms of statistics, frankly, because it's more important than statistics. But how, you know, I think this is a question for all of us in terms of, we know the value, how do we coalesce to communicate and translate that into spend? And I don't know if that's going incredibly well for you guys at Positive the UK, or if that's...
So the project that I was running 2 years of funding and that's it. I've just continued to deliver it because I love it and it's needed. So it doesn't sit with any it doesn't sit within a project anymore. It just sits within POS UK. But I mean, we were talking about that before, weren't we? So it's very much already a conversation with the same questions. Absolutely the same questions.
Maybe in our case, to try to answer it, I mean, we haven't really been able to put a proper figure on it until quite recently, and the figure isn't really the true figure. If you take the fact that I suppose we are all employed by various institutions, and what we've done is we've created space within those institutions. We've like hived off time, and the time hasn't necessarily been during the working day, but this is we've moved it along, and we've done it on tiny money. So I think over about a 24-26 month period, actual money spent on what we've done so far, which is to take 23 people through that course and get 10 facilitators to a point where they're on that road, has been about €122,556. It's
but you've taken loads of salary out of that.
Salary is out of that. So that is just the money spent. That is not opportunity cost. If you factored all that in, and also in kind, and I'm not just talking about our time, but other people who are certified and who've gone and given up 2 or 3 months of their lives in Zimbabwe, scholarships to some of the international schools that are run by the Byron Katie International Foundation for the work. So there's been huge in-kind contributions. The money part of it has been the smallest part. And you have to be a little bit covert, actually, to be completely honest. You're not necessarily keeping a timesheet, at least I'm not, because I don't, you don't always want to draw attention to how much of your time is going in that particular, but it's more of a labour of love, and you spend time outside of work doing it, but we haven't costed all of that, and it would probably.
But then in a way we're kind of colluding, because we're giving so much value.
It's true to an extent.
Colluding?
But I totally get it, because I'm a colluder as well.
Yeah, and I suppose that I'm taking an approach which is kind of pragmatic and looking at a utilitarian approach to the whole thing, where you do that and you collude to a point where you can then knock on doors, and while it shouldn't be about statistics, it does give you the opportunity to talk to people and leverage support and get the bigger money that you need, and not like scale up, go big, because the quality of this is really integral, but replication is what I think it's about. So yes, to a point, but I'm okay with it because I can see where I'm going with it in a sense.
And I think the frame for this kind of is that for positive people needs to move to that positive prevention frame. I think conversations, the treatment is prevention. People that live with HIV are going to be seen, I think, increasingly as part of the solution rather than part of the problem.
Right.
You know what I mean? So I think, if the frame moves from being this is an intervention that's going to cost money for positive people, rather than this is something that will really enable positive people to model effective relationship to adherence and treatment, and as such, make treatment less stigmatized, testing less stigmatized, and I think that may be an interesting frame and way to contemplate it.
So who pays for that? Local authorities do prevention?
Well, I mean, I think the prevention budget clearly isn't working the way it has been spent. Actually looking at the way prevention money is going. I mean, if you're going to look at prevention budget, this is a targeted, strategic way to use it. Maybe trying something that's different, because God knows what's happened today hasn't achieved great results.
Yeah, I was going to say something quite similar. I think that we really do need to be looking, I think your question is very, very important and right. I think we really do need to be looking at very different models that talk about re-inclusion or including anew or getting new populations involved, to actually develop some model that's based on some sort of professional voluntarism process that where people get something in return. The model that I'm seeing that's very interesting right now is one going on in Greece, which is using testing, as the action, but it has involved an incredible number of people in communities as volunteers and as also experts to look at prevention, testing, and then into care. And I think that we all know that there are a lot of people living with HIV or at risk of HIV who on their own standards, doing what they would like to be doing with their lives. And I think that that's what we really do need to tap into. I think it's, I mean, speaking quite personally, I mean, it is what has me doing the work that I do, and I do not get paid for most of the work that I do. And you know, I was raised in a community that did that. There are some questions whether that can be done again. I'm a lot thinking that things are going to get worse, and that you know, now it's possibly a notion of voluntarism, but as we see in Greece, it's becoming a question of survival. And I think that you know, people are facing this in their own lives. What are we going to do to actually get what we need? And they need to think differently. But I also know that there are a couple other people who want to, if we want to continue in this, that's great, or there are other people in the back too who want to continue. Can we let this one go? Okay, do you want to go?
Oh no, actually it's been said.
Okay.
But I was just going to say as well that I think that's where the self-stigma comes in, because I discovered on my own from my experience that I was experiencing self-stigma.
Right.
And it was only after I got over it that I was able to be free.
Right.
And now I walk around and I don't think that there's anybody who thinks that I'm positive, and even if they did, I just don't think about it. I just carry on living my life. But I've realized that a lot of people actually I said it the last time I spoke about HIV, I said, for myself, it was like 90% of the decisions I was making was as a result of stigma.
Right.
And all these things that go on in your head, and because you're not having a conversation with somebody else, they're informing everything you're doing. And so you lock yourself up at home. And the impact is just so huge. And I think that this is actually a really good thing that we need to do, that people need to know that there's self-stigma, and they need to know that they do have it, and then they need to be given the tools that they need to be able to work, because they have so much value, but it's gone if nobody tells them. So it's just the information that even we need to start with as well. Yeah.
I wanted to actually just speak to what you said, and also in a way come back to what you were talking about, Catherine, as well. I said it briefly, but we need a paradigm shift here. We're looking for a paradigm shift in terms of, do we play ball as we've been playing for the last 20 years and continue to the rhetoric of what we've been doing, or do we stand up and acknowledge self-stigma? Personally, every one of us in whatever aspect of your life is able to connect with it, and then do we start to show that by actually being out there and really showing people how it impacts our lives in ways where we have the jobs that we want, or we're doing the things that we want, and that's what we need, the paradigm shift as well as the costing to actually influence people. And I think that's what this is about. And like when we're talking about ReShape and we're talking about the international advocacy, and when you might remember me saying, imagine that we don't have any interventions for self-stigma. You know, imagine now going all the way back to what we've looked at today, and that we really don't have them. So it's about getting that toolkit. You know, here's a few tools that we already are testing and are doing great work. What else is out there? And how do we, all of us, be part of that? So I think there's the advocacy piece, the influencing piece is as important as the costing and other things. But it takes us all to do something about that.
Yusuf.
Got an observation on the question. First, Nadine, you showed a slide from the various stigma indices around the world about levels of self-stigma to make the very important point that self-stigma is prevalent everywhere.
Yes.
As striking to me on the slide was the variation in the levels of self-stigma. And so I think one observation is that whilst an important insight is that self-stigma and stigma that other people in your society have about you don't correspond, nevertheless, to have 16% in Zimbabwe and 75% in Pakistan shows that self-stigma is a social product and a social construction as well, and links to the nature of the society we're in. I made the further observation that there was a direct correlation between the level of self-stigma and prevalence in the country in the slide that you showed. So there's very interesting things to think about, just an observation to add to what you're saying about how there are specifics around each society that have an impact on the levels of self-stigma in the country.
Yeah, great.
The question relates to, and it goes back to what a lot of us are talking about, which is how do we advocate for interventions, particularly to get it funded to get things rolled out at scale, given the degree of need. And thanks everyone for what you said. I found it incredibly instructive. Our job at NAT is to advocate at the policy level. We need as many tools as we can get, and I take the point we shouldn't have to, as Catherine said, but as researchers, what is the kind of peer-reviewed evidence around interventions addressing self-stigma? Obviously, you've applied the work model quite recently to HIV, but as a paradigm, is there a kind of body of peer-review work that demonstrates its efficacy? Presumably, in doing this project, you've looked at other interventions and other models of service delivery, even though they all may be fairly embryonic if this is all new. What evidence is there out there about the kinds of intervention that actually work, that's in peer-reviewed journals that we can start citing to make the case to commissioners that you have to invest in this sort of work and it's important?
Okay, want to take that? A great point about the slides, and there's a whole discussion. There's so much more that we need to do to show self-stigma and to take up this data and to do different things with. So thank you for those points. In terms of the body of evidence, there are no, as far as I could find until now, interventions around self-stigma and HIV that are documented and peer-reviewed. There is a body of work called under the banner of stress reduction interventions that bring together all sorts of things like Sophie was talking about, NLP, mindfulness, meditation. It can go as far as yoga. It can be a whole big basket of things that have been applied to HIV in different settings. So you have something called mindfulness-based stress reduction and other things. And in terms of where we need to focus to generate to generate that kind of engine, my view is that's the best place to look for now. That's the best place, and we have got systematic reviews that we can look to, and in a way we are integrating what we're doing into that basket, because it looks like the basket that we need to open into the HIV field. It's a basket that's untapped, and so we're hoping we're contributing to that basket, and we need to bring other things in. There are some small studies, but they don't really get much traction, because in the HIV field we're very focused on the things that are peer-reviewed, the huge behaviour change interventions, those things that we can all reel off our tongues, and we're just they're so that's what exists.
Yeah. If I can respond to that, Nadine and I met, oh gosh, probably 3 or 4 years ago, and we've done certain things around self-stigma, and it really, and we've been trying to figure out how to get to this step, and it wasn't until I started talking to Alistair and started talking to Sophie about stuff that's happening here that was actually able for us to connect to. And I sort of feel like, for me, you know, in my work, it's drawing attention to those people who are doing the work. And out of that, you know, with people like you, it's saying, we've got to figure out how to validate this. We have to figure out how to present this. And I think it's all of us working together and contributing. Valerie, you've been doing a great job of that, you know, of really bringing things together to ensure. So, you know, my social capital there is really hooking up with people doing work. And I think Positively UK is a group that I'm hanging out with a lot more, both as a person living with HIV, but also is looking for them for guidance. I think 56 Dean Street is another place where I feel like I get challenged, I get involved, and so, and at the same time, really encouraging, Yusuf, your important point about let's get this documented, let's get this, you know, so that we can actually reference it, and you know better than all of us how much has been wasted because of lack of documentation and lack of validation. So we're sort of left at the point of stomping our feet and saying blah, 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 and then, you know, with treatment, basically those who wanted to stop their feet went off, you know, so we're really without people, you know, actually pressuring people for these kind of things. So I think there's a lot of different sources. Valerie.
Just a couple of quick points. I think this has been really, really helpful. In fact, I'd like to hook up to sort of look at the measures and how it's very new for us to analyse these data at Public Health England, and part of it's quite a challenge because there isn't a lot of evidence. But I'm just thinking one of the things that we did want to do in this stigma survey, as Alistair highlighted, was to to also have a resilience scale. So it wasn't entirely about self-stigma and discrimination markers, if you like. And I think one of the things we could look at is the self-stigma, the resilience, and see, you know, if we're trying to build evidence to see how self-stigma impacts on resilience, for instance, in this study, that could be sort of working with you and thinking then how does that impact on people even taking up their treatments or outcomes, etc., which we have in Positive Voices. So we're starting to build up a body of evidence that we could be working more creatively, and I'll come to Catherine for some advice as well of how to look at that, because I think we can design better questionnaires as well that at the end of the day, you know, local authorities don't have a lot of time. They need a few very snappy, you know, even when you come down to it, it doesn't have to be exceedingly powerful data. It just has to be good data in there, sort of there. And I think we need to be creative about that and how to include that. And that was part of the challenge of taking it up. I've had no funding with Public Health England. We're really scraping around, and there's less interest in this work because, you know, it's one of the cuts. So, but I'm determined to keep it there because I think it's exactly that sort of data that we need. There was just another small point. I think we have focused on self-stigma, and I know the whole session might have been broader than that, but it's not to say, and I'm sure you do that in your sessions, that there isn't stigma out there from external, which is Roy's point. And of course, I think, and I'm sure in those workshops, etc., that's discussed first off, and this is very much personal work, but it doesn't take away the fact that we still need and have huge challenges. And if HIV is highlighted in particular, it's probably because of the external, even greater challenges around the stigma discrimination found, you know, faced from outside, of why it becomes a huge stigma in itself. So it's just to, you know, acknowledge all of that, which of course I'm sure the course.
Thank you. I mean, we've sort of moved into a very practical bit as we're getting towards the end. Can I ask that we sort of keep that because we are closing soon? I see you.
Okay, I was just really quick. Are you gonna try and take this as a presentation to the next International AIDS conference, perhaps? Because I know we will be in the various levels.
The stigma index.
Everything that you've talked about now, including the stigma index, but I think this what we're talking about would be a really interesting panel.
Specific, you know, workshop and seminars are really would be very, very,
I think
very much.
I'm sure it's already on your list of to-do list.
We were chatting
do it.
It's funny, we were chatting about it this morning.
Just today.
Yeah.
Oh, okay, great.
We'd love to go quite big with it if we could in Durban. I think it's particularly apt.
Exactly.
You know? And neighbouring country to Zimbabwe, and it would be lovely to do it. We did submit an abstract for the last International AIDS Conference in Melbourne, but the IAS wasn't ready for us just yet. So we're going to give them another chance for
and they've changed
Durban.
But on that as well, while you're collating stuff, where, I mean, I know what you're talking about here is how do we share our stories, but I guess that's the whole point of today. Use us to help boost any applications or whatever.
Well, I think that's a very important point about making sure that we are heard about these issues, and the IAS has been resistant in the past to these issues.
I think the exciting thing about ReShape, though, is brought together in some ways some of the not so usual faces. So if there are dissemination routes or, you know, places that you would like to maybe promote this stuff, this is a great place to start.
George, you had your hand up.
Yeah, so could we do a workshop about HIV and diabetes, and you were saying about stigma around it, and include stigma around living with two chronic illnesses, because the stigma I've faced with my diabetes has been mainly from not getting the right support that I needed, because nobody in HIV organisations wanted to know about it, despite the fact it's the medication that triggered it off. So I've been left fighting to get support. I mean, I'm in a position now that I've got involved with Diabetes UK, who backed me up to set up a website and a support group, and Positive UK just come on board. So there is a need there that we do need to address the problem of what happens when we start having conditions like diabetes.
Positive Voices also for the first time started to record what other people are, what people living with HIV are also living with, all the comorbidities, because we actually don't have until now a really good sense of other, chronic or other issues in people's lives. So that's definitely one of the big objectives of the survey.
And in answer, I mean, ReShape has talked about having a lab around comorbidities, and we are really, really limited with the number of people that we have, so I may be calling you. Because we did.
Can I make a practical point?
Sure.
And that is that I'm a patient representative on my local clinical commissioning group. I'm part of the patient and public engagement group. So I do long-term conditions with HIV, and of course the GPs tell me it's not a long-term condition because they don't commission for HIV, of course. The dreadful consequences of the Health and Social Care Act. But then they let me in because, of course, I'm an expert patient in chronic arthritis. Of course, there are 10 million people in the UK with some form of arthritis. So anyway, last week there was a workshop about a new year of care plan for long-term conditions that the clinical commissioning group held. It was mostly the GPs, business people, people from the commissioning support unit, healthcare professionals, and we talked about how we could involve patients in working out a year of care plan for their long-term conditions. There was a presentation from Claire, I've forgotten her surname, but I will let everybody know, that the Royal College of General Practitioners.
Gerardo.
Pardon?
Gerardo.
No. Claire, no, not a famous name. And she is responsible for rolling out this program. They're using Camden, which is where I live, as a pilot to see whether they can actually make it work, more involvement with the patient. So I was going to let George know about it, but it's only just happened, so I don't have time. And I'm staying in touch with Claire, and I'm going to try to publicise it a bit more. So the suggestion here is that there's some feed in from other long-term conditions into your project around self-stigma, and I think that would be a really great idea for sorting out care plans for those of us who are a bit more complicated, but more common, actually. I think there are 3 billion people with diabetes in this country, around that figure, 2.5 million. So those other long-term conditions are much more common than HIV. So as time goes on, there'll be many more people like that.
I just want to add one thing. I've got three points actually, and mostly around advocacy. They're all disjointed, but we are hoping that the intervention in Zimbabwe is featuring a new UNAIDS report that's still up for clearance for the last 6 months, called Innovative Community-Based Responses to HIV. So it's also looking at positioning this as something innovative and as community-based. So that's one kind of advocacy hook. The other is on the self-stigma, on the actual measuring and the tools and things. One of the things we found, which we didn't get to talk about, there's many different aspects, is we're measuring something so bloody negatively the whole time. How depressed do you feel about yourself? How bad are you? How bad? We're actually contributing to fueling the self-stigma by sticking with the research tools that we have and the crap scales that are validated internationally. So we would like to challenge that, and that's why the RIF scale is actually a positive framework for analysing and reporting back positive change. So by reporting in the way that we're reporting, it's a piece of advocacy, and we're pushing back and saying this is not, this is positive change. So that's fundamental, and I think there's a whole piece around research that needs to be taken up by a lot many more people out there. And then the last thing, one very simple thing you can do is actually the petition that I put up very rushedly on the slides there. That is a declaration on self-stigma. We've called it the Dublin Declaration on Self-Stigma. It came quite organically from a lecture series we had last year, and it's going to be staying up, and we're going to be adding to that petition so that you could help us with, circulate it. And when I mean us because this is something that if you feel strongly about, that can make a difference. And it's very clear. It articulates the issues and why you should be involved.
Thank you. Because I wanted to reference that. I'm really glad you brought it up again. I think it's on the ReShape Facebook page. If not, it will be. I think it's a really part of what I wanted to talk about, didn't have a chance to talk about, is your sense of how much habit you need to develop to actually make this stuff work. So I think that looking again at the information on ReShape about this increases our awareness, because if you're as difficult understanding as I am, it helps to reinforce this information over and over again to actually get self-stigma, stigma, discrimination. So first, I'd like to thank you all for coming. Thank you very much. You've been a very positive audience. I especially want to thank Nadine. We've been trying to move this thing along for a while, and you've been doing great work. I think the Irish statement is really a good contribution to that, and also the work that you're doing in Zimbabwe, I think, pointing to Steve being thank you too. And to thank to everyone who's been participating, and to Sylvie and to Nia who've been working.